medwireNews podcast. At the 2018 British Society for Rheumatology meeting, we spoke to Professor Ramanan about managing uveitis associated with juvenile idiopathic arthritis. Professor Ramanan was the lead author on the recently published recommendations from the SHARE initiative, which covered screening, diagnosis and treatment of this condition. First of all, could you tell me why guidelines on JIA-associated uveitis are needed?
So children with arthritis, when they get uveitis, even in 2018, have significant complications from it. So about 40 to 50%, or 1 in 2 children who are diagnosed with uveitis associated with JIA get some form of ocular comorbidity leading to visual impairment. And there is a huge variation geographically within countries as well as amongst countries in the way these children are screened, diagnosed and then managed. So having a European guidelines which can be then used globally is important so that the standards of care for children is equitable and also in reducing the morbidity we see with uveitis.
And what are the main points covered by the SHARE initiative guidelines?
The SHARE initiative looks at diagnosis, screening and management. Because this uveitis associated with JIA is asymptomatic, screening is crucial in picking up this disease. So defining how often these children should be seen, which children should be seen with arthritis, and then giving broad principles or construct of management in when they should be using topical or eye drops which contain steroid, when they should be considered using systemic steroids, which is only in rare occasions, when they should start a disease-modifying anti-rheumatic drug such as methotrexate, and when they should escalate from methotrexate to another drug such as a biologic.
What, in your opinion, can rheumatologists and ophthalmologists offer each other?
Significant working together would mean that we can learn a lot from ophthalmologists about the nature, course, and the complications associated with these conditions. Ophthalmologists are the ones who diagnose uveitis, who monitor the disease, who look out for the complications of the disease. But what the rheumatologists offer is significant experience. Usually we've been using most of these medications such as methotrexate and biologics for 2 decades now. So we bring with us the experience of using these agents in children. But we need the help of the ophthalmologist in deciding when to start these medications depending on what they see in the eye, and when to escalate treatment depending on what they see in the eye. And this is best done for both effective delivery of care for the families and the children if we work together, preferably in the same room, at the same setting, same appointment.
Are there any challenges associated with collaboration between rheumatologists and ophthalmologists?
There are significant challenges. In many institutions, they may not be located within the same hospital, they may be in neighboring hospitals. There are challenges in ensuring that the hospital authorities understand the value of 2 professionals working together. Sometimes they may think, why are 2 consultants required to see 1 patient? Could they be working better, more efficiently if they both saw them separately? And then in breaking down the barriers between the specialists themselves, the ophthalmologist may feel that more time is being taken up in these combined appointments, so they would be seeing less patients. But most of these are surmountable with the right will between them.
Do you think there will be any challenges or barriers to the uptake of the recommendations from the SHARE initiative?
So the SHARE initiative's primary goal is to ensure uniform standards of care across Europe. And we know that even within the same country, there is quite significant differences geographically. So there are going to be challenges. But what these guidelines will provide is a template for clinicians, ophthalmologists and rheumatologists to take to their regulatory authorities, to their hospital administrators, to say that these are the standards of care that are expected across Europe. And hopefully this will provide that much needed template for them to achieve those uniform standards of care across Europe.
Do you know whether there are any studies planned to look at how the guidelines are uptaken in different areas?
No, but it's a very important one. We need to understand, we don't know what the level of provision of care across Europe is, and then what the deficiencies in different setups are. But I think it's an important point you raise, and it would be worth trying to look in a couple of years, if not at the adherence to these guidelines, which is one way of auditing how many of these centres in different parts of Europe adhere to the standards of care that's published.
What impact do you think these guidelines will have?
I think these are the first guidelines which are derived by going through the evidence with a consensus of 9 rheumatologists and 3 ophthalmologists. So they provide a valuable base for people to base their practice on. And if these guidelines are followed, I think there will be significant upscaling of the standards of care and fairly uniform level of standard of care across Europe. And if we are able to achieve these guidelines, I think it will go a long way in reducing the morbidity that we see from uveitis in children.
What further research is needed to better establish the optimal treatment approach?
A lot of research is needed. We are screening a lot of children to pick up a complication which is seen only in 15 to 20%. So we have no effective markers of identifying who is going to develop uveitis and who isn't. And in the absence of those effective markers, we are wasting a lot of resources in screening a lot of children to pick up something. So we need to invest in trying to pick up biomarkers for who is at risk of developing this complication. We also need more research once they've developed this complication of how to treat effectively. We are using disease-modifying drugs such as methotrexate, and we now have shown evidence for biologics such as adalimumab. But there are always lots of questions on whether dietary interventions can help. Parents are always keen, whether complementary therapies can be effective, whether there is still about 30 to 40% of the patients who don't respond to both methotrexate and adalimumab, what therapies are effective in them. There is a whole new class of oral agents called JAK kinase inhibitors, whether these will work in uveitis. Children and parents of these children struggle with current medications. Methotrexate gives nausea in half of the children who take it. Adalimumab is an injection every 2 weeks, which very few children, leave alone adults, will enjoy. So these are the core areas of research. How can we screen better? Can we come up with a biomarker to identify who's going to develop uveitis? Can we trial new therapies, particularly oral agents like JAK kinase inhibitors, to effectively treat these children?
So, these guidelines are an important step towards delivering consistent standards of care for JIA-associated uveitis across Europe. We look forward to future studies on potential biomarkers for predicting uveitis risk, as well as clinical trials of new agents to treat the condition. Thank you very much to Professor Ramanan for sharing his thoughts on the guidelines.